Hey, welcome back to Crashcart Nursing. Today we're talking about time management, but not the version you learned about in nursing school,
That's
not the checklist version because that falls apart fast when real life happens. So today we want to just go through all these different things that can help make you more successful as a nurse, whether you're a seasoned nurse, whether you're a new grad. Talking about tips and tricks that can help you be more effective at managing your time. Time management in nursing isn't just about being organized, it's about surviving controlled chaos.
So I know when you're in nursing school, right? Like you go and you do your clinicals and you're looking at all of these nurses and you're like, oh my God, this was actually just said to me like last week by a student. How does this nurse actually like all of this stuff was happening? I couldn't keep up. But she was just on it. Like, how does that happen? So it's kind of like a muscle, right? Prioritization is something that the more experience you have, the easier it becomes. So when you're in nursing school and you're beginning to get out into the field and all of those good things, it can feel a little overwhelming. But this is where, if you go back, if you're in your first semester, or even if you're in your last semester of nursing school, or honestly, even experienced nurses or new nurses who are listening to this, if you go back way back, right? First semester nursing school, and think about like your Maslow's hierarchy of needs or your ABCs, right? This is something that the more you get it ingrained into your brain, I think the easier it is to prioritize, right? Because it almost becomes habit. So when you think about even just Maslow's, right? It's this pyramid where you have your physiological needs right at the bottom, right? Your safety, your belonging, your esteem, and your self actualization. So, the idea behind Maslow's hierarchy and kind of a good starting point of learning how to prioritize, right? Is you can't build the top of the pyramid, right? If there's not a stable bottom. So we have to make sure for our patients, right? Are their needs met? Are their bodies able to maintain homeostasis? Honestly, is probably the easiest way I can even think about that. So do they have food, shelter? Are they warm? Are they comfy? So are they having those basic needs met? And then kind of as we go up in our priority list, are the patients safe, whether it's physically or mentally? Do they have a sense of belonging, right? How is their self esteem? How is their confidence? And then self actualization is where we start to kind of get into like this idea of our patients are actively trying to become the best version of themselves. So, and then same thing with our ABCs, which I feel like kind of focus more in that bottom, tier
Definitely.
of Maslow's where we have airway, breathing, and circulation. I know, Nick, you are probably an absolute expert on ABCs because it really I would imagine it's really ingrained in triage, no?
It is, and I feel like that if you're in the emergency department, nothing has to do with self-actualization. Like
Yeah,
really
nothing.
nothing. Everything is life and limb. Probably the closest that we get is with our mental health patients that are coming in crisis. But even then, you have to make sure that all of those basic tenets are met before we get to that point of self-actualization. Like that's not something that is from the emergency standpoint is not something that we're fixing. You know what I mean? We
Yeah.
are stabilize and treat, get them to that right resource, which is mental health hospital or wherever, outpatient therapy, all of those different things. But it's not the same way that you would look at it if you're somebody who's like, I'm just trying to help them. It always feels like out there to me, like, because I'm trying to deal with that base
Yeah.
level, like you
Yeah.
mentioned. And so I think that that's where some of this like idea of I don't really care about all the high up stuff. A lot of nurses fall into that category because most of the time we're treating physiology that's at the basic levels impaired.
Yeah. And I think that's an interesting point is that depending on where you work, your goals in this are going to look a whole lot different.
Yes.
So when we say become familiar with these, start to exercise this muscle of prioritization and learning how to pick out what's important, these are really, really good starting points. So, if you're in a clinic, you're a little bit you're kind of more in the middle of that pyramid, right? Compared to if you're coming into the ER with both of your legs cut off, right? You tend to be in a little bit of a different box. So, it's just
You
really
can fit in a
important that
box if you don't have both your legs. I'm just
you
kidding.
can. I mean, you could. You're
Bad
not
jokes.
wrong, but so it just kind of depends where you're working, right? And that's one of the things I think Nick and I are going to explore in this episode is just how do you know where to start, right? How do you begin building those types of things? And it's going to be really fun.
Yeah,
I'm excited to talk
absolutely.
about it.
So, depending on where you work, the story of what prioritization looks like, what time management looks like, it can be very different, right? So, we want to give love to every department today because no matter where you're at in healthcare, there is some kind of time management that has to happen. There's some kind of planning out your day that goes on. And some of it may be flying by the seat of your pants, but I think that we all can agree that there is an ideal way to run our shift and there's a non-ideal way to run our shift. And the question is how do you end up making that day feel like you're put together rather than the chicken running around with their head cut off? It's really a difficult thing. I actually have gotten this question before in interviews and they're like, what does your ideal shift look like? Has anybody ever asked you that, Courtney, or anything like it?
Not really, but I have some answers. I
So
do have
for
answers
me,
to that.
for me, if I'm like interviewing for an ER job, that was the first time I ever got that question. It's like, what does your ideal shift look like? And I'm like, well, the ideal shift, it's like every IV's getting sunk. There's no issues. I can, when I go around and talk to my patients, they provide urine, they do all the things that I ask them to do. Workups come back clean. No blood samples are hemolyzed. Teamwork makes the dream work. I get my lunch, like all these
Yeah.
things are happening. And they're like, so what
What's
do you
that?
do if that day doesn't happen that way? And one of the things for me that I learned is peace in my own self in the ER doesn't happen because of extrinsic factors.
Mhm.
Peace happens within myself because I manufacture that, right? So I have to think about how do I want my day to go? What do I want it to look like? And knowing that sometimes there's going to be some crazy flexibility that has to happen on my part of like, am I going to let X, Y, or Z derail my day? Am I going to let simple things get in the way of me having a good day? So I think it's totally possible to be running your ass off and crazy and still have a good day. And some of it is just about that critical thinking component. So, maybe you've got 4 patients, maybe you've got 5 patients, maybe you run a whole long term care facility and you got 30 patients down your hall that you're taking care of. And it seems like the moon must be misaligned and everybody is running around naked, whatever. Are you going to let that ruin your day or are you going to rise to the occasion? I think it's possible to be successful in all of the above. Your ICU day might look insane. Like you may have the crashing patient that keeps coding
Mhm.
over and over and over again, and who has the, luck of the draw to where they keep having crappy things happen to them, but they're also super lucky and keep staying alive.
Yeah, yeah. I've definitely had days like that. Now the good thing about the ICU is that if something like that is happening, because I have definitely had a patient that I've coded, 7, 8 times in a shift. And the good thing is that normally if you have another patient, there's a lot of teamwork that happens. And usually someone will help take over your other patient. And honestly, sometimes that's the best thing you can ask for is just having a good crew and someone's helping you out. But the one thing I can say about the ICU, and that's having worked in places like tele and ortho trauma, and I started out in long term, right? So I've even kind of had a taste of what it's like having 30 patients, honestly.
Ugh, yuck.
Is in the ICU. Oh, dude, we'll talk about it today because I
It's
got
not my
something to
favorite.
say. I like really empathize with the nurses when we go to clinicals. I'm like, yes, girl, I get it. Is in the ICU, thankfully, we don't usually have like chunks of time where we're really, really busy. It's just kind of more, unless your patient is sick, right? Sometimes this is most of the time, not all of the time. It's just kind of like steady busy, which actually is helpful because I feel like it makes the shift go by quicker.
But if you're steady busy,
But
you probably have a flow of how you want it to go, right?
yeah, I
And so
keep
you
notes,
come
I
in
write
at the
things
beginning
down.
of the day, kind of plan out your day of like, where are you going to be? What do I need to do? When are all my
Mhm.
meds due? Right.
Right.
And so I think, like I said, depending on where you work, this can look drastically different, right? So a med surge nurse, you might have your 5 patients. You know that you have 9 o'clock meds due. Everybody's got something due. So you really need to be in 5 places at once. And you've got your hour long period of time where you can give meds depending on your policy, right? So some places it's going to be you have a half hour before, half hour after, depending on how critical the patient is. Other places you might have an hour before, hour after, so you've got that 2 hour window to give those meds. But either way, you've got multiple demands coming from different directions. Where do you go first? And then to top it off, you've also got family members who are asking
Mm-hmm.
questions, who want to talk to you, who want to know what the doctor's going to do. You have somebody who's heavy on the call light, or somebody may not look right. They might be deteriorating, and it's all a matter of the question of where do I go first? How do I manage this? And you go into one room, you get interrupted, a call light goes off, you're trying to chart, your phone rings, and then you're just behind. And
Mm-hmm.
how do you manage that feeling of I'm behind?
Yeah, it's hard. It's hard, guys. The big thing is I will always say this: learning to trust your gut. I feel like is a pretty big thing, right? If you're like, ooh, I should probably go look at that before I sit here and do this, just to give like a really exaggerated example. Your patient's hypotensive, but you're late on a colace. It's really okay to
Yeah.
wait on that colace, right? Because when you look at the Maslow's hierarchy, the hypotension is going to fall in that bottom tier, but the colace is going to be, it's a scheduled med. Like, it's not great to be late, right? But someone possibly deteriorating is always going to take precedence over an over-the-counter
Yeah.
medication, right?
Well, and that's the thing, though, is that like priorities change. When you look at the picture first, it's easy to see, okay, the hypotension takes precedence, and then you kind of put the colace off. And then something else comes up and you put the colace off again. And something else comes up and you put the colace off again. And now all of a sudden, you have this patient with a bowel obstruction because you never went back and got
Mm-hmm.
the colace taken care of. You know what I mean? So it can go the
Yeah.
opposite way. So it's prioritization. I can put this off, I can put this off, but at the same time I also don't want to put it off so long that it becomes a problem that I could
Mm-hmm.
have prevented. You know what I mean? That the order was in and I could have prevented, and I still have to get it in that time frame. So like toward the end of that time frame, all of a sudden that becomes a priority now. So I think
Right.
that this is a paradigm that a lot of people struggle with, because it's like, well, it's not that important. The colace isn't that important, but the colace is still due, and the colace is still a provider
Mm-hmm.
order, and that colace still needs to happen. So the question with time management is, do you know when to call for help? Do you know when to say,
Yes.
hey, I am swamped, and charge nurse, I really need you to give a colace because it's really low priority, but it still has some place on that priority index, right? And it
Mm-hmm.
still needs to be taken care of so we don't end up in a problem with that patient.
Yes. And I'm so glad you said that, because that's actually where I was going to go with that too, is that you will never be without a lack of a resource, right? There's always something, there's always somebody to help, right?
Yes.
I know a big
Or
part of
if there's
nursing
not
is
and you call and you say, "Hey, I need help," and they say, "Hey, I can't do it right now." It's like, "Okay, cool. I'm going to try to do this," and then it
mm-hmm,
might just be a sneak attack, run by, throw a colace at them
and
and head
throw a
out.
colace at them and leave, you
Here,
know?
take it.
But I think it's also important, and maybe we should talk about that today too, is like kind of what those, like maybe what resources are available, because there's so many, and it's almost impossible to know them until you needed them and they kind of present themselves. So maybe we'll tell you guys about some of those things too. I think
And they
that's
may be
really
facility
invaluable.
specific too. I mean, you
Mhm.
need to ask and find out, what does my facility offer as far as help. And I remember as a new nurse feeling like I don't even know when I'm too far behind to where I should be asking for assistance, or like you
Mhm.
said, I don't know what resources are available to me. How do I go about taking care of this? Or is there an order that a provider has put in that is like, this is not reasonable for the level of care that they're at? Does that patient need to be escalated to a higher level of care? Because like, if you're asking me on a med surge floor to do Q 15-minute this or that, like, I'm sorry, we've kind of moved out beyond that med surge load of what this should be. This
Yes.
patient needs more intensive care, and they may not need a full on intensive care, but they might need a step down or something like that, in
Uh,
order to take care of it.
So I really like that you brought that up because I actually have a really good like real world example of this because in the ICU, right, when we get CWAS, we're giving like Ativan or Valium or whatever it
Like
is
it's
that's ordered,
candy.
Pheno, like it's candy. It's almost kind of crazy. Like sometimes we're like, ooh, that's a lot.
That's why I hate having alcohol withdrawals in the ER for a long time. This is a
Yeah.
huge problem in the ER from my own experience, and maybe it's not this way everywhere. I love my ER docs, but alcohol withdrawal gets drastically underdosed in the ER,
Yes.
and we end up with just horrible delirium tremens that are not managed well enough with benzos in the ER. And I feel like a clinical pharmacy really helps with this because they will be like, hey, what about a loading dose of phenobarbital or
Yeah.
something like that. And barbiturates are dangerous, right? Inherently, and we try to avoid them. But in patients with severe alcohol withdrawal, very, very helpful to have a
Yes.
loading dose of phenobarb and then to switch to benzodiazepines. But a lot of times they'll be like, here, give them 2 milligrams of Ativan. And I'm like, cool, when can I give that next? And they
Yeah.
don't ever
Don't.
put that next dose in.
Yeah.
And how's the CWA range in the ICU as far as that? Like 2 milligrams of Ativan is a drop in the bucket. Like it is nothing.
It's nothing. That I can remember, and this was actually for this patient is what's kind of crazy is they were, and it's funny because my husband's a nurse, and so it was actually on his floor. And I was charging, and so that's why I remember it because I was like, wow, this is actually insane. Because when you're dosing CWAS, right, it's a lot easier in the ICU to stay on top of that every 15 minutes, giving Ativan. We also tend to keep more controlled like substances and stuff in our pick system and like higher volumes of like the multi-dose,
Yeah.
vials
Don't
of
you guys
Ativan
do
and
like
stuff like that.
multi-dose vials of Ativan, like 20 milligrams or something like that?
Yes, and we were giving this patient 16 every 15 minutes and it was not touching him. And I remember
For
it
those
was
of
almost kind
you,
of sad.
for those of you who are new to the nursing field,
Yeah.
16 milligrams of
That's
Ativan
a
would drop
lot.
my 230-pound ass and make me sleep or dead for a week.
Like just for like when you get a migraine, because I get migraines, and like when you go into the ED and you get a migraine cocktail, they're giving you like 0.25, like 0.25. And we were giving this person um at every like 15-minute intervals, we were giving this person 16 of Ativan. And I remember just like look because they come in the 20 milligram vials or whatever. So that was also how we found out that we can't just pull, the four or whatever out. They were like, so we were having to waste the 4 milligrams, which also felt
Oh
incredibly
my
wasteful.
gosh,
But
that is so wasteful.
it was like every 15 minutes we're like having to give that, having to do a CWA, like wasting the like 4 milligrams of Ativan. And it was just like we made like a little, this is so stupid, but we like made a little pyramid out of the vials.
Oh my
It
gosh.
was crazy. This poor guy too, because it was wild. Like that's an obscene amount of Ativan to give someone. But this patient was originally on a med surge floor, and
And they
so
were given that much in med-surg?
no, that was we pushed for them to come to the ICU because I was charging, and like when stuff like that happens, your ICU charge nurse is usually aware of like some of those things that are kind
Hmm.
of happening around the hospital, just so we can keep an eye out for them. Same thing with like your crisis nurse. Like if there's someone who's requiring a lot of care like that, we're usually aware of them. But in med surge, I believe they could only give up to two. And then it was like they were gonna send him to Telly, but Telly they could only give like up to, I think it was 6. I could be really, really wrong about that, but we were like, no. That first of all, that's an obscene amount of Ativan to be giving someone every 15 minutes and like
Sure
not have
is.
the capabilities to like have RN eyes on like their monitoring and stuff. But like that's just not realistic. It's not realistic to take someone who has 6 patients and be like, "Okay, no, you have to give this Ativan every 15 minutes." Like
Well, and
it's
so
just
see,
not
that's
going to
where the
work,
problem in the
you know?
ER comes is like you've got this person who is withdrawing, and maybe they
Mm.
write for an initial like 2 milligrams of Ativan, and I give the 2 milligrams of Ativan, and it literally doesn't touch it. and
It does not touch it.
you're like, hey doc, I really need to give them more Ativan, and they're like, well, we're going to get them admitted to the ICU, and in that time, if they end up boarding in the ER for any length of time, they're acting nuts. Like, you're
Mhm.
dealing with this patient that is off the rails, and it can be a long time not really having a time frame of when are they going to go. And so, like, you can be advocating for them, and the doc might be okay, like, yeah, let's give them another 2 milligrams of Ativan until they become nuts, and then you're holding them down, and it turns into a whole like restraints and intubating the patient because they're just so far gone. And like, if we just treated better with Siwa in the ER,
Mhm.
and if your ER does it better, please drop it in the comments. Like, we want to know, what do they do?
Yeah.
How do they manage that in the ER? Like I said, in my own practice, I have not witnessed this to be something that is managed greatly, but I would love it to be something that is managed well. But it is time intensive when you have to do that. Because
Yeah.
I mean, you look at a CWA rating, and it's like, I always feel like whenever I've done CWA in med surge or in the ER, like, you do that CWA scale, and by the time you're done with the CWA scale and you've medicated them if they need it, you're back to doing the CWA scale again, like pretty much immediately. And
Mhm.
it just feels like this constant continuum of going through CWA with them, which is what they need in order to make them successful. And like I always tell my students, the reason why we need that CWA scale is because alcohol withdrawal is the most deadly withdrawal. Like,
Yes.
you can withdraw
Causes
from anything.
seizures.
Yeah,
For
you
those
can
who don't
withdraw.
know, that's why we give them benzos.
Yeah, you can withdraw from most other things and not die. But alcohol, if you're withdrawing from that and you go into these delirium tremens, you end up going into a seizure that you can't come out of. You end up status epilepticus and you die.
Mhm.
And that is a huge detriment. So, this is why, if you have a drinking problem, please don't try to quit drinking by yourself. Or if you do, you better go with the slowest taper.
Mhm.
Cold turkey alcohol withdrawal is
Is
stupid.
never
Like,
it's
it
never
is
a good idea.
dangerous.
Yeah. It's very, very dangerous.
Like, you want to
And I've
give up meth, give
actually
up meth. You want to give up freaking heroin, give up heroin. Like, you're going to feel like death, but like, you can give those up and be okay. But,
Mhm.
quitting drinking is something you need to do with a licensed professional helping you.
Yeah, and I always like to tell people too, because I mean, like, even family. Honestly, really, anytime I'm doing patient care, educating about alcohol, just be honest. Please be honest. None of us care how much you drink. None of us. No one who is going to treat your alcohol withdrawal is going to care how much you drink. What I care about is being able to take care of you. I also don't
Absolutely.
care what you took, right?
Yeah.
I'm not the police. I just want to treat you.
Yeah. And I think that that's a huge trust thing, right? That we can
Hmm.
make sure that our patients know is like, hey, look, I'm not here judging you. Like,
Yeah.
um, I'm assessing and I'm asking questions because I want to be able to help take care of you. And if I don't know what you took, it's really hard to
It's
take
really
care
hard to
of it.
treat you
So
if we don't
I,
know what
I
you
can
took,
have
but
speculations and I can have some good clinical judgment, but that doesn't mean that I know exactly what you took, and it doesn't mean I know exactly how to reverse it.
mhm. But no, that guy that we were giving that much Ativan to, we ended up having to put him. I think we tried Valium, and because we were using a lot of Ativan. Like, there's only so much Ativan in the hospital. You know what I mean?
Yeah.
But we ended up. I'm pretty sure we ended up switching to Valium, and then that still really didn't do anything. So then he did end up getting a pheno drip. We ended up
Yeah.
loading dose and giving him a pheno drip. So
And for those who are not sure, like, why is a barbiturate, why is it a problem? So barbiturates in general have a low therapeutic index. So the amount between what is safe and therapeutic and the amount that is toxic is very, very narrow. So you have
mhm,
this narrow therapeutic index. So just a small window where it works great. And then the chance of having somebody go into a point of becoming so apneic that they are, needing ventilation is really unknown. If you look at different drug books about phenobarbital or any of the barbiturates, that's why we have kind of narrowed down when we use them. We only use them in specific instances, and really an advanced airway needs to be available if they are going to be put on stuff like that, because that window is so small and you
mhm.
could be giving a normal dose and still overdose somebody. It could be even
Yeah.
a relatively small dose, and it could overdose somebody, obviously, depending on their kidney function, liver function. So, this is why we're very cautious with barbiturates in general.
Hmm. Yeah, barbiturates definitely. I did work though at a hospital. I traveled to a hospital that I, that's just what they used.
Interesting.
It,
It's kind
it
of
was
old
very,
school.
it was very old school. A little bit of a smaller hospital, which I think probably had something to do with it. But I remember being like, that's interesting. I don't.
It is always interesting because there are different methodologies and thought
Hmm.
processes depending on where providers went to med school. Different thought processes based off of locale of where you live and availability of drugs and
Yeah.
what pharmaceutical companies are in that area. Obviously, we know that pharmaceuticals are a huge industry. And so you got sales reps who are going out in different places and
Hmm.
kind of pimping out their stuff, and
Pimping out.
depending on what is popular in the area is what people are going to use and what's easily available too. So, I mean, I know that supply chain during COVID, we all experienced supply chain shortages and different things. You just never know what is going to be recommended based off of what's available. So each center might be a little bit different. So if yours is different, you're like, we never use this or we always use that. That might be why some of that's happening. You're like,
So Nick, I kind of want to just ask because you and I come from very, very, very different worlds in the nursing. So I know our day looks like totally different. And I'm honestly, as someone whose main experience, right, is in the ED, what does that look like to you? Like, what does time management look like? What is the perfect day? What is something that maybe doesn't happen in other specialties that kind of derails you? Curious to hear about that.
well, I don't think anything like super derails me. Like I can go with the flow pretty much wherever I'm at. And I think that for me, time management is most effective when I can go with the flow of whatever comes up. So you just kind of take the punches and roll with them.
Hmm.
But like what does a great day look like? Well, it might start off with I feel like it's a lot easier to come into a shift in the ER when you don't start with empty rooms. So sometimes like in the ER we kind of work into our day for day shift, and then for night shift you work out of your day. So like it might be crazy chaotic, maybe not right off the bat, but it can start pretty dang rapidly. It just depends, right? So every day is a little bit different. So if you come in and all your rooms are full, to me that's easier to come into because most of them are going to be settled. Like there might be one new patient in one of my 5 rooms that needs to be seen right away, but hopefully orders are done and that's easy to kind of roll
Yeah.
into, right?
Right.
Where it can be more challenging is like say the night shift cleaned house and got everybody out the door and there's not a lobby full of people yet. If that happens, which is not common, right? It's more common to just have patients all the time. But if that happens, I feel like that's where you can kind of feel like you're really chasing your tail is like, oh crap, I went from, maybe 1 or 2 patients to start the day to now I'm full and I've got 3 that I need to see at the same time. So from a time management standpoint, it's looking at chief complaint because that may be all that I have and maybe that first set of vitals. So I'm looking and I'm just immediately going into that prioritization algorithm of what's perceived problem and what is reality with based on vital signs, because that's really the objective data that I have at that point. I may not have a lot of other info. And then the triage, the people, they do a good job of like if they're bringing somebody straight back to a room, if we have rooms
Hmm.
available and they're triaging them at the bedside, if that's happening, it's like they might call an EKG overhead, they might call for a blood sugar overhead, they might call a code stroke, right off the bat, they're calling a lot of the stuff. So it's helping prioritize for me because triage is already seeing them and they're like, hey, this
Hmm.
person needs to be seen first. Or they might have just dropped a patient in a room and said, hey, this one has this going on. And like, if I'm in the middle of doing something else, I can make that decision split second and be like, do I need to drop what I'm doing and go see that patient? Or can I finish what I'm doing? You know what I mean? So
Yeah.
it just depends. It is always a little bit of a cluster, but the benefit is for me is like there is somebody else kind of helping with that, helping drive that. And then as we work into our day and our department gets busier, we add more staff. So that means we open up more rooms. That means the department gets more busy and chaotic if they're not already open. or it means that we add more floats who are going around and helping with critical patients or, whatever, wherever they're needed.
Interesting. That was going to be another question I had, is because I know the couple times we've talked about like the differences between ICU and ER. I'm how does someone else know that your patient needs a bolus and they just go and do it? That
So that's one of the nice things with like using like tracker board and ED. We have different
mhm,
tools. It's set up a different way. So like you can see from the tracker board without even logging into all
yeah.
those patients. So like in med surge or ICU, like you grab your patient in Epic or Cerner or whatever system you're using and pull them over. And like Epic on the tracker board for the ED, it shows all the patients out there, and like I can pull my own into my little group and see just
Mhm.
mine, but I can also see the main tracker board and see who has orders that are due. And so people will just hover over that. They don't even have to enter into the chart, but they can see like, okay, this person's got a normal saline bolus that needs to go in, or this person needs, a line in lab. This person needs an EKG. It's still outstanding. And it may be in progress already happening, but a lot of times what'll happen is like we'll have a float roaming the department and
Mhm.
they'll just go check and see like, did that thing happen? If not, they'll go in and they'll just take care of it or whatever. So it's like we're all
Hmm.
kind of helping each other out, and this team nursing system really kind of prevails, and it's super helpful. But at the same time, like you can feel like if you're somebody who's like, these are my patients, don't touch my patients, that can feel really intimidating. Which for me, I'm like, hey, if I can help out my fellow team member, like that's great, you know.
Yeah. I don't know. That's an interesting kind of workflow to me because,
You still have primary nurses, right, who are assigned to the patient. But like,
yeah,
say I'm in deep with a chest pain that just turned into a STEMI, and
right.
they put an abdominal pain in another one of my rooms. Like the provider might go in and see that patient before I do. So this is the hard part where I think a lot of nurses, they want this flow of like, well, triage sees them, then I see them, and then the doctor sees them. Like that's great in a perfect world.
Hmm.
But sometimes it's triage saw them, put them in the room, while they're still in the room getting triage done, the doctor comes in and sees them and puts in all the orders. And so then you feel behind. Like that happens.
Yeah.
And, but if I'm dealing with the STEMI next door, like I'm glad that they got seen by somebody. The patient felt like they got taken care of. It just means now I got to go hurry up and do stuff.
Hmm.
So
That's interesting.
it is a
I was
different
never
dynamic.
quite sure how that worked because it does work a little bit different. I think inpatient
Oh, for sure.
works a little bit different. Not that there's not this idea of like a team nurse, right? Because teamwork makes the dream work. Like you have to have a good team, right? Just to get through your day most
It's just
days.
more
But
specific roles in patient. Like you're like, hey, I need you to do this.
yeah.
And like you're more delegating tasks, right? Whereas I feel like you have a lot of autonomy in the ER world where you have a bunch of nurses who all have the same credentials. We all
Hmm.
do the same thing. So maybe I'm assigned this person as primary, but like my coworker notices like, hey, he's stuck in with this code STEMI or code stroke. He's not going to be out of there for a bit. I'm just going to go take care of his other patient. Or they're busy also, and that doesn't happen. And that person is sitting there waiting. And that's kind of a bummer too, right? So
Hmm.
like, oh, the doctor came in and saw me 45 minutes ago and nobody's been in since. I'm like, well, yeah, sorry, I was coding the person next door, but you can't say that. It's just, I'm sorry, here I am, let's do
Oh,
it.
sometimes they know and they don't care. Sometimes
Yeah,
they know and they don't care because I've definitely been yelled at not bringing water.
a
When their
blanket.
like neighbor
Yeah,
has 10 million people running in and out of
yeah,
the
I'm
room.
sorry, the person next to you just died.
You're like, I'm so sorry about your blanket, but I'll go get it for you now.
Yeah, my toe hurts, or like, I
I
understand it
mean,
does. I'm sorry. I'm really sorry that happened. Which is why I
that's
try,
bad, but
if
it
I'm
does
ever a
happen. Happens
patient,
a
I
lot.
try to be a great patient and just be chill and not push the call light, not
Do you know, speaking of that, this is more of like a personal story, but the first time my migraines, right? I lose my sight. Like
no.
I go, yeah.
They
And so the
code
first
stroke you.
time, well, no, because this I was literally sitting there the very first time it ever happened. I was literally sitting there just like watching TV and I was like, I can't. Like I'm like trying to read the caption because we watch captions
For
on our
sure.
TV. And I was like, oh, my vision looks a little weird. Okay, that's fine. And then I remember I started losing like my peripheral vision, and I had asked Ernesto, I was like, what, like, when do I go to the ED, right? The answer is when I was looking right at him and couldn't see half of his face, but I was definitely doing like a B fast with my camera,
Hmm.
like this in the phone. But the very, very, very first time it happened, I was actually in the ED for a totally unrelated thing. And I started like losing my vision. And I am so conscious about trying to be a good patient that I like hit the call light. They came up over like the call light little speaker, you know, whoever it is. And I was like, hey, sorry to bother you. I'm losing my vision. And I don't really know like what to do, which is not the thing to say in the ED, by the way, if you come, you know.
Well, that's how you make a lot of friends quickly.
I did make so many friends. Yeah, really quickly. It was fine. I didn't stroke out. Turns out I just have migraines, but it took me about another year to figure that out.
So
So
did
it's
they
funny that you
they
say
do
that.
like the whole thing, CT angio, all the stuff?
No, because like I had literally zero other symptoms. They just kind of I'm a woman, so they told me that I had anxiety and gave me some Ativan. I took a nap and I felt much better.
And they were right.
Yeah, they were right. It you know, so it worked. I was fine. But I remember being like, "Oh my God, I don't want to be a bad patient." I'm like, "Hey, I'm going blind. I don't know what to
But
do
it's
about
not
it."
being a bad patient to tell us when something changes. It's actually being a good patient, right? Like we want to know if something changed so we can fix it.
I'm like,
That's
"Oh
so
God,
funny.
please don't be mad at me. I know you're so busy." So stupid.
Yeah, so I just feel like back to your question of like the ER of like prioritization, I just feel like it is so much just being able to go with the flow, roll with the
Mhm.
punches, which some people they don't like to operate that way. But no matter where you're at in nursing, I feel like that there is some component of flexibility that we need to have. So, in med surge, it can be everything's just do at once. Like everybody's got stuff on the same time interval, which is really challenging because how do you be five places at once? And the answer is you can't be.
Mhm.
In ICU, you don't have as much volume, but there is a lot of depth to what you have to do for each person. So I feel like you can plan a little bit more and kind of anticipate. And the other benefit too that both of those departments have, and Tele falls in that same category, right? Is like you have the same patient over time. Like in the ER, I see somebody today, I'll see 25 different ones today or more depending on acuity level, or less depending on acuity level. But I see all of these patients and I'm not going to see the same ones tomorrow. Like if I see the same patient tomorrow, they're probably a psych hold and they're usually very stable and there's nothing crazy that I have to do unless they ended up in restraints for being violent or something like
Mhm.
that, which that's a whole nother beast and nobody loves to deal with that.
Nope, nobody loves that.
So if you're an outpatient, it's about flow. Maybe you work in a clinic. Um, you don't have high acuity patients, but it's a flow. So you can kind of get in this flow state of like, what do I need to do? And again, that can feel like things get messed up in the flow state when maybe a provider goes and sees your patient before you've seen them. And you can feel like that they're kind of stepping on your toes or pushing you from a time management standpoint. So some of this is communication, right? Of like, hey,
Mhm.
how can we make this flow better? Um, and then in long-term care, I think that the problem is that here you have so many tasks to do, so many patients to take care of. And one of the things that really concerns me with long-term care is in my own interactions that I've had being a clinical instructor, I've never worked long-term care except as a CNA, but I've seen it even then, is this opportunity where nurses will pass off responsibility of things and say that they're delegating. And we kind of get into these unsafe conditions. So I do want to encourage our long-term care staff. And here's what I mean, like specifically, like if workload's too high, we sometimes trade safety for efficiency. Like think about if you have a post-fall patient. If how many of you have ever heard somebody say, well, they're a post-fall patient, we need to do neuro checks. And I know I have seen this at every long-term care facility. And what do they call a neuro check in those places, Courtney? Any idea? What do they do?
I can only speak at what I would do, which was a
Yeah,
full neuro
a
check.
full neuro. But I've seen
But
people trade safety for efficiency by they hand it off to their CNA and say, do vitals this often. and they're just charting vitals. Well, guess what? If you are waiting for your patient's vitals to decompensate to show a true neuro change, then they are already screwed. You have waited too long. You missed the early changes in a neurocheck. And can a unlicensed assistive personnel, UAP, can they do assessment? The answer is no. And I don't care what state you're in, according to the Nurse Practice Act, you cannot delegate the act of assessment, right?
Mm-hmm.
And so they're saying, hey, CNA, hey, MA, hey, whatever, go do the vital signs as a neurocheck. That's not a neurocheck. So delegating the vital signs itself is fine, but delegating that assessment of neurocheck is not fine. And when we do that, we are trading safety for efficiency. And that scares me as a nurse. Like, I hate seeing that, because I fear that we got into this place of where we're trying so hard to manage our time throughout the day that we're cutting corners in a way that is making our patients unsafe.
Right. And it's really hard in long term, because like I said earlier, I did work long term. So I do understand with 30 patients. First of all, the saving grace there is that you get the same patients every single time, because
For sure.
you start to learn, oh, room 12 has this wound change. A room, I don't even know, 25 has they're not going to take their bowel meds. And so you kind of learn, but all nursing is very task heavy. Like, I understand that, but long term is like a totally different beast when it comes to being task heavy, because
Well, for sure.
most places you do still have like only that 1 hour before, 1 hour after. But with 30 patients and you're having to like crush every single one of those meds, right? Half the time, 80% of them, right, I worked on a locked dementia unit. So a lot of my job too was convincing, right, the patients to
Yeah,
take their
please
meds,
take
because a
this.
lot of the time they get distracted, or they, don't want to take their meds, or they're,
Or you have to
not
learn
really.
their little trick of how to get them to take it. It's like,
Yes, because
you
some
can
patients
mix it
won't
with
use
this much
applesauce.
applesauce. You can mix it with this
Yeah.
much pudding. You can mix it with this much Jello or whatever. Or, you know what I'm
Mm-hmm.
saying? Like, or like, how many of them are getting Miralax and they're mixing that powder in, and they're like trying to get them to drink all of that fluid is
Mm-hmm.
almost impossible. And if you don't give them the amount of fluid, it's not going to work anyway. You're just giving them a gut bomb. Like,
Exactly.
they're just going to feel terrible.
It's not even, it's also like, think about, so if their meds have to be crushed, right? Sometimes they have or not tablets, capsules, right? So
Yeah.
then you're having to like open the capsule. And then sometimes if you're having a really bad day, they loved thickened Pepsi the day before. And then the next day they're like, nope, I want chocolate milk. And you're like, okay, well, we don't, all right, let me go re-pull all of these meds. And because like you have to take them, I can't
Thickened
just not.
liquids.
And everybody's on thickened liquids,
Yeah.
it's
These are real
kind of,
challenges.
they're real challenges. And then like a good day is everybody takes their stuff, like everybody's awake, everybody is, I don't want to use the word compliant because I hate how medical that term sounds, but like everybody's agreeable, right? You're not having to spend a lot of time to like convince them to take it.
Yeah.
But then God forbid something happens that is outside of like what you need to do. Like if a patient decomps in a long term, it's shift ruining, honestly. Like it really is, because
Well, and
you have another nurse who has 30 patients, and then
I think
like,
sometimes though people aren't even recognizing when their patients are decomping, because
mhm,
we get so task heavy that we're not actually assessing anybody, right? And to me, time management with patients like this, when you have a really heavy load of patients who maybe are not critically sick, or like especially in long-term care, we see this, right? Is how do I effectively go in and assess all of these patients without having to do a formal assessment? Like, maybe they have a formal assessment that's due once a week or whatever, or once a month. Like, some of them do not need an assessment all the time, but that doesn't mean we're not assessing. So here's how I encourage my students to do it. I want you to go into a room, and when you go in, talk to the patient, but I want you to try to notice 10 nonverbal things about this patient. And that can include safety risks in the room. It can include just their overall appearance. Like, how did they look across the room? at looking at them. What's their color look like? How are they breathing? Are they on any oxygen? Is there any medical devices that are attached to their person? Are there fall risks or trip hazards in the room? Do they have their grippy socks on? Like, what are we talking about here? What, do they have a crash mat on the floor if you're in long-term care? Is their bed in the low? Do they have their call light? Are the lights on? Can they see?
Yeah.
Do they have their visual aids? Do they have their hearing aids? Do they have the things that are going to make them be successful to prevent a problem? So prevention is so important in those places, but a lot of the times it's go in, hey, here's your meds, bye. Well, that's not really an efficient way of using your time. Like it's efficient from the standpoint of getting your meds done, but what did you not prevent? So if they fall
Mhm.
and they end up on the ground and now you're having to do neuro checks, do you have the time to actually do those neuro checks? Are you actually doing a full neuro assessment like we taught you in nursing school? And the answer to that is probably not. So like my students, if I'm at clinical with them, I'm like, I swear to God, if you're doing a post fall algorithm and they put in a neuro check, I want a neuro check. You're going to give me their neuro check. You're going to write out a little narrative note for me and give me the
Mhm.
neuro checks that you did for that patient. And then let's look, did they change over time? And I don't care if the nurse isn't asking you for that as a nursing student. Like, so if you're in clinicals right now and you're like, how do I get the most out of my clinical? Do real nurse stuff. And that would be
Mhm.
if you have a post fall patient, go and do the post fall assessments on that patient and write some stuff down and really see, okay, now where's the disparity? Is the nurse that you're with, are they doing that much or are they doing less? And they're probably doing less because they're burdened by time. But so here's the thing, if that patient does decomp, and let's say that they go down this pathway of having a sentinel event where they have fallen, hit their head, they hemorrhage internally, and they bleed and they die. Let's just say, worst case scenario, if that happens, is your documentation that you're putting enough to cover you? And
Right.
I would say that most nurses in long term care are going to say no, unless they go back and they chart it after the fact, after that sentinel event happens, when they ship that patient out and they go back and they're running around like a chicken with their head cut off, trying to make up for the fact, which is not ethical, right? So, and that's a whole nother
Mhm.
thing. That's an integrity issue. So, really, you got to ask yourself, is what I'm doing enough? Would a prudent nurse do what I've done? And I think that if we take a good, long, hard look at long term care, in a lot of ways, we're going to be like, we're kind of falling short. So if you're a
Yeah.
long-term care nurse, this is no shade on you. This is not your problem. This is a system issue. But
It's a
you need
system
to
issue because
but
it's
you
hard
need
work,
to
man.
raise the red flag to leadership of like, I'm sorry, if we're just getting vitals on patients when they have fallen, that's not a neuro check. It's just
Yeah.
not.
I feel like this is difficult because when you take it to your leadership, learning which keywords to use, getting your concerns documented. Now, whether or not they do anything is not on you, but it is important. I would argue when you bring it up, you're creating this trail that you were advocating, which I will
Absolutely.
never apologize for advocating for a patient. I will never apologize for pushing for my students to advocate for your patients. I honestly think that's like the most important thing we can do as a nurse. But even if what you're doing is unsafe, like Nick was saying, it's a system wide issue. Okay. This is not an attack on you. It's hard freaking work working in a long term care. It is so hard.
Absolutely.
I would argue that it's undervalued work, to be honest. It's difficult. And we know a lot of you are doing the best that you can. And it's a system issue. And if they're
But
not doing
protect your
anything
license.
but protect your license and get your concerns written down, right? Use the keywords like unsafe. Those are big, big things, right? And just cover yourself because then if something does happen, then there's at least something, right, that you
Yeah.
brought up.
Well, and so here's a way that you can look at this, and we didn't really talk about this in our communication episode, and it's one thing that I wish that I would have brought up. So I'm going to bring it up now. If you are finding yourself in a place where there is something going on that is unsafe, so Team Steps, the same people who brought you SBAR, they also have a tool called the Cuss tool. And it is another way of communication that we can use that alerts people in leadership, alerts doctors of we're saying, hey, we got to stop. And so Cuss stands for concerned, uncomfortable, and this is a safety issue. We need to stop. Okay. So we're not actually cussing at them. But I've actually done this with provider before, and they're like, are you cussing at me right now? And I was like, yeah, motherfucker, I am cussing at
Oh
you.
my God. I've actually never heard of
You've
this. I
never
mean,
heard of
I've
this? So it's
I've
a
called them like safety huddles, like safety stops. We're gonna stop what we're doing and
yeah,
talk
it
about
is
it.
that. It is absolutely that. But it can be just a quick thing. So it's like, hey, doc, I'm concerned about this patient because this is going on. I'm uncomfortable because of X, Y, and Z. And I think we need, and like if they continue it, I think we need to stop because this is a safety issue. And if you've done that, you've used the cuss tool. If they recognize and hear, it should be something that it makes them take them. It should be something where they stop right where they're at and they go, "Hey, I just noticed you use the cuss tool. Let me
Mhm.
really pause and listen and make sure that we're not missing something here that we need to be doing." Right. So if you take it to your leadership and you're like, hey, I need to cuss real quick. This is a standardized tool. It's not as widely used as SBAR, but it comes from the same people who make SBAR team steps. I know a lot of organizations do team steps, certifications, and things like that, especially at a leadership, executive, director level, because it is critical communication pathways. And this is a great opportunity to use that. Because here, let's think about it. Let's go back to that story of if you've got somebody who's fallen and you do the post fall algorithm and you're doing your vital signs as your neuro checks. If you miss decompensation, we've delayed the problem. Okay. But now instead of 2 minutes of doing a neuro check every hour or whatever your facility protocol is, now you have somebody who's coding. Now you have somebody who needs to get shipped out. Now you have somebody that you need to print a packet for. And I guarantee you that rapid response escalation takes way more of your time. I guarantee you that if you have a code, that takes way more of your time. And it's something that you might not have been able to prevent, but it is something that you can at least have documentation to that is like, hey, I noticed the problem was going down this way. And maybe you ship them out before it's a full-fledged emergency. And now you've just saved yourself a bunch of time or whatever. And it's really just better patient care. It's all about what does the patient need. At the end of the day, we get put in this position where we're in charge of people in the aspect of in charge of their overall health and helping take care of them. And because it's been entrusted to us, I just feel like it's a huge responsibility. And, to whom much is given, much is required. Like, if you want to have great responsibility, you want to have this, profound impact on nursing, you want to have, even if it's just a job for you, but you want to do a good job at this, you got to realize that there's a lot of responsibility on our shoulders and we need to do a good job.
I agree with that. So I guess my question is, because I'm kind of thinking about like if I was back in nursing school, right? And I'm thinking about what you just said. How would you encourage maybe a new nursing student, right? Because you've got a couple more years of teaching on me. How would you encourage a new nursing student to go about this, right? Because it can be kind of intimidating, right? To speak up and to advocate for your patients and to honestly advocate for yourself. Like that's definitely something that gets easier, right? How do we do that?
In the beginning, I think that we ask a lot of questions to try to gain understanding. So we don't just automatically come off with our recommendations, right?
Mhm.
So if we go back to our nursing process, before I can apply interventions, I must assess, right? So if you're seeing inadequacies in your system, ask more questions. Hey, why do we do it this way? Hey, I noticed this. Why do we do it this way? Can you tell me more about this post fall algorithm and what should be happening? I just want to make sure that I'm being thorough and complete and doing the right thing. Ask questions of your leadership. Like, I noticed that you only have vitals here listed as something that needs to be documented. Is there a reason why we don't have a neuro assessment as a part of a neuro check? Like, to me, like, why are we calling it a neuro check? Like, what's a neuro check? It's a neuro assessment. So shouldn't that
Yeah,
be part
right
of it?
now we're just doing a
No.
homeostasis check.
Yeah.
Like, is
We're
their
just
blood
checking
pressure
vitals,
right?
bro.
Like, we're just checking vitals. We do that all the time, right? But that's what separates you
Well, and
from.
is there a protocol that says, if the blood pressure drops by this much, then I call a provider? Or
Mhm.
if the heart rate goes up by this much, then I call a provider? Is there any of that in the protocol? So ask first, what is the policy? How do we take care of this? What do we have written down? Right? Go according to your facility policies. And if the policies are not robust, Or if you notice, like, hey, I'm in orientation and my person that I'm following doesn't follow that full policy, like maybe you're asking an internal question is like, am I going to do that when I'm out by myself? And like the answer for me would be, okay, they may have shown me and demonstrated a way that was not appropriate, but I'm going to do it the appropriate way. And I don't care if everybody else doesn't do it the appropriate way, right? We've joked a lot about comments and things that people have made of like, I don't, that report was too long or that report was too short or they asked too many questions or they did this or that. And like, y'all are entitled to your own opinion. But at the end of the day, it's my nursing license and I'm going to protect my own nursing license the way that I see fit. And that means I'm going to follow policy. I'm going to follow procedure. I'm going to go according to what a prudent nurse would do, right? Because that is ultimately what is required of me by my board of nursing, by my Nurse Practice Act. And some of y'all have probably never read your Nurse Practice Act. And so you really don't know. But I hope the day of reckoning doesn't come for you in that way, because, where you get sued, where you get subpoenaed, where you have to speak to what you did or didn't do, because I want to know that I went at it and I did the things of the best of my ability to be great at my job. And if I get subpoenaed at that point, at least I can know that I did everything I could to be successful and to do a good job for my patients. So I'm not so much worried about other nurses thinking that what I do is stupid. I don't really care because I'm just trying to do my best.
Right. Right. And that was another thing. I can't remember if we talked about this when we talked about our communication. So I'm also going to say this here because one of the things that I feel like I get a lot of questions on from like the nursing students who are just starting to go into clinicals is when we're focusing on SBAR and they're like, well, how do I know? You know what? Report is such a personal thing. You are never going to make everybody happy.
It's
You
true.
are never going to make everybody happy. It is what it is. Like, you do what will make you, just like you said, a prudent nurse. And you can never, ever, ever go wrong about that. If somebody's mad because the report was too long, sorry
Get
about
over
it.
it.
If they're mad because it was too short, sorry about it. Like, everybody has different ideals of what that's going to look
Yeah.
like.
At the end of the
Everybody.
day, we all are just trying to do our best, or we should
Mm-hmm.
be, right? Um, Trying not to cut corners and trying to make sure that we have integrity. I think for students, like, this is why I will preach this to my students over and over again, is like, we care about your integrity because at the end of the day, nobody's going to be with you at the bedside for everything, right? It's you and your patient. So we get down to brass tacks of like, if you break sterile field, are you going to fix it? Are you going to go and get a new catheter? Are you going to, fix the problem? If you drop a pill on the floor, are you going to pick it up and give it to them? I know we all get tempted with different things like that. The question is like, what are you going to do? What
Mm-hmm.
does your integrity tell you to
Yeah.
do?
Where
What
does
is
your
the right
integrity
thing?
lie?
Yeah, where is it? And like, I can keep giving all my meds late. I can keep doing all those things. These are all integrity issues. These are all matters of like your heart, of like, where are you at? And sometimes I feel like, people cut corners because they feel overwhelmed or whatever. But if you're feeling that way, that's where you need to ask for help. And so I think our goal really here is to help switch you from being like that nurse who just makes it through a shift to being that nurse that's competent and good and high quality, right? I want to put out high quality nurses. I want nurses who pass
Yeah.
the NCLEX, and I want nurses who studied more than what they needed to study. I don't want just bare
Yeah.
bones. I
Yeah,
want
I
a
want
smart
nurses
nurse.
who aren't afraid to ask questions when they don't know,
Exactly.
right? I want a nurse who's confident but not overconfident. Like, I want a nurse who knows what they know and is not afraid to admit what they don't know because it's really
Absolutely.
okay.
And like, for me, like, I've done this a long time, but there's still stuff I don't know. There's still stuff that I'm asking questions and I'm like, I want to know more about that. And even some of the stuff y'all have commented, like, I want to know more of like, how are you doing it in practice? And so I can learn and update,
Mhm.
my repertoire by knowing more and learning more. But I want to be somebody where my colleagues look to me and they go, Nick knows things. He knows how to make stuff happen. But there's also those times where I'm like, I don't know. And I think that is a much better place to be, to where you can openly admit, like, I don't know how to make this better. How do what are your thoughts? How do we do it? Uh, and I think really good nurses complete their orders. They make it through their shift, sure. But great nurses really set goals for their patients and help move them towards goals. I think is the next level time management.
Mhm.
To segue into that, I want to tell you a story about a lady that took care of my son, Gabe. Her name is Amy. She worked at Seattle Children's Hospital. So, Amy, if by chance you hear about this, or somebody from my friends list, because I do have some of those nurses as friends on Facebook and TikTok, if you know Amy, Amy was like the most amazing nurse. And Amy was actually a really big inspiration for me to become a nurse, because every day that she worked with our son Gabe in the Seattle Children's Cardiac ICU, Amy set goals. Amy moved the needle toward Gabe getting better. When Gabe was born, he had hypoplastic left heart syndrome, basically no left ventricle. He was super, super sick kid from the time he was born until the time he died. The benefit that we got is because of nurses like Amy. We got to have Gabe outpatient with us for several months. And that was a really, really great time because he was smiley and on oxygen, but he was a happy little kid. And we got to do like some normal stuff with him. Took him around Seattle and around Boston when we ended up transferring to a Children's of Boston. But it was so cool because when I watched Amy do her thing, it was like every shift that Amy came in, Amy had goals for what she was going to do with his vent settings. She had goals for where she was going to take him in that shift. In that 12-hour shift, it was her little piece to his journey was, what can I do to improve Gabe? How can I, make him breathe better? How can I do different, like what interventions can I do? And she made a plan every day. She had great time management. She had her stuff together. And this is back in the days of paper charting. I mean, like we're talking 2013. She's up there planning this stuff out, which the whole ICU charting was like, they had just like these massive sheets that were out, and
imagine.
it was insane. Like all the stuff that they're writing.
Imagine.
But she would plan out her day and she would put it on the whiteboard and she would tell us, this is what my goals are for Gabe for today. This is how I'm going to help make him better. And she noticed deterioration better than anybody else because she had specific goals and specific outcomes that she was aiming for. And it was something that really encouraged me to, like, when you're a nurse, Nick, don't just settle for the status quo. Because we definitely had nurses who came in that he would stay right where he was or he'd go backward when they were there. But they also weren't pushing to try to make him better. And I'm confident that Amy is a huge reason why Gabe ever got weaned off of a ventilator. I don't think that if she hadn't been there that would have ever happened. I think that if we had status quo, all the time like that he would have stayed on the ventilator for much longer and probably died much sooner. So she noticed when his sats dropped and he had a change in his shunt had occluded, and like she had 2 SpO2 probes on him at one point. He had like a 7% oxygen on one hand and like an 11% on the other hand. And she got him in the cath lab right away. They fixed it. And, I think that if it had been a different nurse on that day, I don't think we would have ever gotten Gabe out of the hospital, honestly. So I think it's all about, what's that?
I said, that's a great nurse. Amy, we love you.
She was a baller, dude. Like, Daisy Award winning, like, I'm just a wilted Daisy, a little bit jaded.
Yeah. I do want to throw this out there real quick. Just because you don't win a Daisy does not say anything about your. I've never even been nominated.
I have never been nominated either. That's what I'm saying. I'm just a wilted Daisy kind of award winner.
To put that out there, that does not mean you're a bad nurse, but that's awesome, Nick. Honestly, and I love hearing about stories where, like, it's really cool to know, right? 10, 15 years down the lines, like that could be you guys, right?
It will be you guys. You're gonna affect somebody's life.
You affected someone's life so much that now this many years down the line, like, people are looking at you fondly, and I just think that's really special. And I feel like a lot of people don't get that opportunity. So
if you had told me back then that I'd be a nurse and we'd have a podcast and we're talking to, future nurses and affecting all of that, like that is the butterfly effect of all of this, is like that there are people right now that are in our nursing program that we are helping steward their education, that will go on to do amazing things, that will affect people in ways that are profound. And I can't wait to see what they are. And maybe you're out there listening and you're like, I don't know, maybe I could be a nurse, maybe I couldn't be, maybe you're intimidated, maybe you think I'm not smart enough, maybe you think like I didn't have high enough grades in high school. Well, guess what? There's a difference between high school and college education, because high school education, you kind of just had to go through, you're forced to. College education, you get to pick. And when you
Yeah.
get to pick your college education and decide what you're passionate about and you put your effort into it, it is so much different. Like, you might be somebody who's like, I never could succeed at doing homework. And now all of a sudden you're writing papers and you're getting scholarships and you're doing, like, it's crazy the difference in what it can be. And so, like, I don't care if you're in nursing or whatever profession that you're going into, find something you're passionate about and pursue those things. And it's amazing the results that will happen.
Yeah, it really is true. If you pick something you like, you'll never work a day in your life.
I don't
That's
know.
very,
Some
very
days still
true.
feel like work. I really like this job, but some days definitely feel like work.
I don't know. I'm in a great mindset. Honestly, if you would have told me a year ago that we'd be doing what we're doing, and even that I'd be, honestly, even a year and a half ago, if you would have told me I'd be teaching, I'm like, no,
Yeah, it's awesome.
no. It's like awesome. So you never know what's gonna happen, guys. That's the cool part. That's the cool
Yeah,
thing.
exactly.
Just put yourself out there and do the best you can, and it'll be a good time.
Absolutely. All right. So let's give you some practical tips for time management. Number one, do the things that are going to blow up first. Stuff that's going to
Yeah.
fall apart, things that are off the rails, do those things first. I think that this is
Mm-hmm.
obvious. Obviously we're going to prioritize everything just like the NCLEX says that we should. Airway, breathing, circulation, all those things come first. We talked about Maslow's hierarchy of needs. We got to fill the base first before we can get up to self-actualization, intimacy. All of that stuff is later on. Doesn't matter if we haven't
Mm-hmm.
met the baseline first. So that's an NCLEX concept. You can take that to the bank. You do those things first. If those things are impaired, if those things are infringed upon, you have to take care of those things first. So if you're looking at a question, if those things are affected, take care of those things first. In real practice, if those things are affected, take care of those things first.
Mm-hmm.
Do the big
Right.
stuff first.
Right. I think another important thing is, just as a practical tip, cluster your care, right?
Yes.
The more you can do when you have the time and you go into a room and you're like, okay, this technically, not counting like scheduled things, but like this technically doesn't have to be done for another 2 hours. If it can be done, then just do it. It
Yeah.
will
Hey,
make your
I'm
life
here and there's
so
nobody
much easier.
pulling me out of the room, so I'm going to do it.
Hmm.
Right.
That's why we always talk about charting at the bedside. If you're having a good start to your shift and you have the chance to, that's part of clustering your care. Is just getting it out of the way, doing what you can, setting yourself up for success, because like you don't know what's going to happen in the next 12 hours of your shift or 8 hours or
Well, and
whatever it
I
is.
think sometimes people think that like we have to do all these, like, oh, we have to do Q 2 hour rounding. And I always ask students this: why do we round every 2 hours? Anybody know? And the answer is always like, well, because that's standard of care. Okay, but why is it standard of care? So here's the answer. Q 2 hour rounding came because that's how long it took Florence Nightingale to walk around the camp in the Crimean War. So when she was
I
rounding on
didn't
her
know that.
patients, that's how long it took. There's no evidence or magic to every 2 hours. Can your patient develop a pressure sore in an hour? Absolutely. Can your patient develop a pressure sore in 6 hours? Sure. The number is arbitrary. Okay. It's something that nurse leaders have put on. But Q 2 hours originally came because of that. It was like, okay, so it took Florence and her girls 2 hours to go around and see everybody. And they'd be like, we'll be back in about 2 hours because that's about how long it takes us. There's no magic in that. It's just an arbitrary number. So
Hmm.
if your patient needs more help before that, go help them if you're available. If you get busy doing other bedside care and it takes you a little bit longer, there's no magic in that 2 hours. Now, your facility may have written a policy around it saying nurses will chart every 2 hours on their patients, but that's an arbitrary thing. It's not based in science. Like, stuff can go awry much sooner and stuff can go awry later. Okay. So
Mm-hmm.
the point is like, you're always prioritizing. You're always, going to be behind in some way. That's the question that you have to ask yourself: is what matters in the next 10 minutes? What matters right now in front of me? Keep that stuff in front of you, because you're always going to feel behind. And if you're feeling behind, you're probably doing it right. It means that you're prioritizing and you're taking care of the things that are right in front of you in that 10-minute window of like, what do I need to do right now? What do I need to do next? And we're constantly going back and fixing it.
Mm-hmm. I think another big thing too, never fake your vitals in your assessments, guys.
Please. Yeah.
That's
Never.
another big thing. You will see that. Honestly, that's just kind of something that will happen. You will see it. I've seen it. I'm sure Nick's seen it a million times.
It's why
Don't
there's
fake
all
your
the
stuff,
memes
guys.
about respiratory rate of 16,
Yeah.
right? And like we've talked about that in prior episodes that like your respiratory rate is actually very telling vital sign. It tells you
Yeah.
when somebody's starting to decompensate. So don't lie about it. And
Mm-mm.
teach your CNAs that it matters too. Like learn how to count it. Learn how to count a real respiration because it matters. Chart the actual stuff that's actually happening and
Mm-hmm.
just chart the things that are really going on.
Yeah. Just be a prudent nurse. If you do
Absolutely.
that, you're set. You'll hit all of these boxes, right? Exercise the prioritization muscles, exercise your critical thinking muscles. Always try to learn because you're never going to know everything ever. And that's okay. It's just the name of the game.
Absolutely. So just know that speed comes with time, right? And time management isn't about being fast, though. Time management is about being somewhat organized about where you want to be. And it's also about being focused. So it's totally normal to have that feeling of, I'm not caught up, I'm behind, what am I going to do? That's a normal thing, but it's just all about focusing in on what's important. What do I need to do right now? I remember reading Stephen Covey wrote a book where he talks about, there's this whole framework of like what is urgent is not necessarily important and what is emergent may not be important at all. And so it's determining your own in your life, what do I need to do? But there can be non-urgent things that are important to do, and there can be non-urgent things that are not important to do. So we want to make sure that we live in doing important things, whether they be urgent, emergent, or non-urgent, making sure the stuff that we're doing is the most important thing to do. And obviously in medicine, we have to prioritize the emergent, urgent, and non-urgent, but there can still be important things in all three of those categories. So, but which one needs to come first? Obviously, the more emergent, important thing needs to come first. But patients will bring things to you that are emergencies to them that are not important at all, like getting the water for them when you're dealing with a postcode or
Or
whatever,
they're
or a
a little
warm
hungry.
blanket. They're a little bit
Yeah.
hungry. Like it's important, but it's not urgent. You know what I'm saying?
I like that. I like that because I feel like sometimes, and honestly, this is myself included. I'll put myself on blast. I don't care. Just because you have an idea, right, of what's going on, and you're like, well, actually, your turkey sandwich is nowhere near my top priority right now. To them, it is. And I feel like sometimes we forget that just as nurses in general, because we have so much going on and it is such a busy job. Like, really, no matter where you're working, that I think that's important to call out is that everybody is allowed to have a bad day. And I tell this to my students all the time because they'll be like, I know people have it worse than me. It doesn't matter because to you, right, that's a big deal. So I think it's important to also put that on our patients and stuff like this.
Definitely. Well, and it's okay too to just say like, hey, I'm going to get that to you when I can. I've joked with patients depending on rapport that I have with them of like, we go off of a priority list. It's airway, breathing, circulation, and turkey sandwich is way down on the alphabet here. It's not even truly in the alphabet, but
Yeah.
that doesn't mean that it's not important to you. And I've told them that, like, I will gladly get it for you in just a minute. Like, I got to take care of this first or whatever.
Mm-hmm.
Like,
And
but
sometimes that
at the same
transparency
time, I
goes
can
a
just
little
grab
bit.
something quickly too. So there are times where we can adjust and flow. And that's finding
Mm-hmm.
that flow state. And some days you're in the flow state and everything flows. And other days it is a no state
Yeah.
and it just sucks.
Some
And that's
days,
just what it is.
like you get in your car and you've just blacked out the entire day. You're like, I don't even know what just happened.
And that's where the music is loud, or you're just, raw dogging at home
Yeah,
with
you're
no
just
music and just staring.
no music. Do you know, I've actually had Ernesto said he's like, I've never done that. And I'm like, what's it like to be just so mentally sound that you can just have a horrible day and just jam out and not be worried about it? Because
For sure.
sometimes the days are you get home and you just sit in the car, you know? You're like, I
Yeah.
don't even want to
Like
go
I need to
inside right now.
decompress.
Like my legs aren't working right now, you know?
Yeah, absolutely. Hey, everybody. Thank you so much for watching this episode of Crashcart Nursing. We'll see you next time.
Yeah, thanks, guys.
to everyone.